founding president of Avoidable Disease Network. Actually, this special session is the first session of 2025. So, yeah. Yes, thank you very much for joining our special session. So today's session is role of emergency medicine in reducing avoidable disease. So this is a special session. Yes, I think emergency medicine is one of the key element reducing avoidable disease. And then because I live in the Japan, so yeah, we fortunately can access emergency medicine in time. But yeah, I think timely intervention is quite important to reduce avoidable disease. So yeah, today I'm as one the participant, or I would like to run from two. I think today we have two presentations. Yes, so two presentations about emergency medicine in mainly low and middle income countries. And then I hope we have a good discussion about this, the topic. So thank you very much. Yeah, so before we move on to introduction of ADN and then to presentation, I would like to briefly in show our housekeeping rules. So could you show next slide, please? Yes, thank you very much. So please ensure that your microphone remains muted during the entire special session. So if you have a question or comment, please type it into the chat box. So please do not use your microphone. Instead, use the chat box, and then we will pick your comment or questions. And this special session will be recorded and published online after we finish this session. So if you do not wish to be seen, please turn off your camera. Each section of the each section of the session will be timed. So yeah, because of the time difference, so some people join very late night. So yeah, so the keep time is quite important. And there will be a pre and post session pause. So this pause is not evaluate the speakers, but for our, the special session. So yeah, we want to improve our session. So yeah, your cooperation is highly appreciated. Okay, thank you very much. Yeah, so this is today's timetable. As I mentioned, we have ADN, the introduction by Professor Nivedita Lebenet. After that, we have a report. Then we have two presentations. And after that, we have 10 minutes for question and answer. Then we'll have post poll. Yes, so this is today's program. Okay. Yes. Okay, thank you very much. So before we move on to welcome address and presentation of ADN, I would like to ask you all to show your camera if you don't mind, because we want to take, the photos of this special session. So yeah, if you don't mind, kindly turn your camera. Right. So Kelly, can I ask you to take screenshot, please?
Yes. Moment.
Big smile, please.
A smile, please. Yes. Okay. Yes, that was done.
Great.
Thank you all.
Okay. Okay. Yes, thank you very much. So let's move on to welcome address and presentation begin. So yeah, Nivedita, please.
Thank you, Hideyuki. Kelly, if you could run my slides, please.
Yes.
Okay. Although belated, Happy New Year to you all. As Hideyuki said, this is our first knowledge exchange event. So welcome to our first session. So esteemed colleagues and our wonderful speakers and ADN members, good afternoon from the UK. It's very windy here, so it's a windy UK, I would say so. So thank you for joining us today. This is our first knowledge exchange event for 2025, and we'll be running quite a few of knowledge exchange events till July 2025. My name is Nivedita Ray Bennett, and I'm Professor of Risk Management based at the University of Leicester School of Business, and I'm also an Associate Director at the Institute for Environmental Futures, which is also based at Leicester University. So we can move to the next slide. Little bit about ADN. So Hideyuki and I launched the Avoidable Deaths Network in 2019 at the Global Alliance for Disaster Risk Institutes at Kyoto University in Japan. We can't believe that it's already 5 years. So ADN is 5 years old. And it started the idea of ADN came from my book, which is right on the left-hand side, Avoidable Deaths. And it was launched by me, Hideyuki, and one of my PhD students, Denise Corsell. Now, Denise has graduated with PhD, so she's Dr. Denise Corsell. Over these years, ADN has grown. So let's move on to the next slide. So now ADN is a global and local membership network of experts, practitioners, and researchers interested in avoiding human deaths from natural hazards, naturally triggered technological hazards, and human-made hazards in low and middle-income countries. But we also work in high-income countries, such as I'm based in the UK, Hideyuki is based in Japan. We also have regional coordinators based in high-income countries, such as Canada. We can move to the next one. So we are often misunderstood as an NGO, but we are not. ADN is not an NGO. ADN is based. So if we could move on to the next slide, Kellyanne will come back to this one a bit later. Yes, so ADN is based at 2 universities, University of Leicester in the UK, where I am, and Kansai University in Osaka in Japan, where Hideyuki is based. Leicester offers MSc in Risk, Crisis and Disaster Management, which is a distance learning program. And Kansai University offers BA and BSc in Safety Science. And both universities offer PhDs. We offer PhD in Management, and Kansai University offers PhDs in Safety Science. So if anybody is interested in taking any of these courses, please get in touch with us. Now, ADN is a member of United Nations Office for Disaster Risk Reduction Sendai Voluntary Platform. We also become a member of UN OCHA's Humanitarian Networks and Partnerships Group's Leading Edge program since last year. And from December last year, we became a member of the UNVRR and UNOPS Santiago Network. So if we go back to the previous slides, a little bit about the demography of ADN's members. So ADN currently has more than 900 members from 94 countries. And this means that, we are present nearly 50% of the UN member states. And our top 10 countries, you could see they are largely members from the top 10 countries are from UK, Nigeria, Bangladesh, Pakistan, Uganda, Indonesia, Sri Lanka, and Afghanistan. Japan does not appear yet, but maybe in due time, we might have, members from Japan. It's partly due to language issues. Now, these 900 plus members represent more than 700 organizations from all sectors. We also have chapters in India, Bangladesh, and Oman. But for some reasons, Oman chapter has been a bit inactive. But otherwise, the India and Bangladesh, both chapters have been doing exceptionally well. We can move to the next slide. Can you the next slide, please? Yeah, and the next. Okay, so a little bit about ADN. Yeah, why do we exist? So ADN, we exist to help policymakers, researchers, practitioners, and at-risk community make better decisions to save lives and reduce injuries to achieve sustainable development. Little bit about avoidable deaths. You've heard me saying quite a few times. So we understand avoidable deaths are premature deaths that could be avoided through tailored, preventable, treatable, and governance-related measures. These are three main reasons we focus on avoidable deaths. Right on the left-hand side, you could see that. So first of all, reducing avoidable deaths, we believe, is a matter of social justice because the burden of these deaths is carried by the vulnerable sections of society. And justice can be redressed by drawing attention to these premature deaths so that the capacity of health emergency and disaster management systems can be developed, as well as context-specific interventions can be put in place to save lives. And secondly, we also believe that zero casualties is a reasonable target. It's a reasonable target than zero damage. And finally, avoidable deaths directly contribute to the United Nations Sendai Framework's global goal number A and B. So A is reducing disaster deaths by 2030, and B is reducing the number of people affected by disasters by 2030. Now, these two global targets of the Sendai Framework work at the interface with 4 SDGs, which are 3, good health and well-being, number 11 is sustainable cities and communities, number 13, climate action, number 17 is partnership for the goals. But recently, the WHO released the World Status Report on Drowning, and ADN works on drowning, and they identified 9 different SDGs that directly connects to reducing drowning deaths prevention. So we have currently, subscribed 4 SDGs, which is on the website of the UNDRR, but otherwise there might be, it has connections with several other SDGs. On the second column of my slide, we believe strongly on networking because ADN is a network, so avoidable deaths network. So we are a network, and we believe networking is important for reducing avoidable deaths. We understand a network as people and organizations, or a group whose members exchange information. We have different networks consisting of various different types of individuals and organizations. There is a saying that each one of us has more than 800 networks. And these multiple memberships of a network can bring new insights. So we can mutually learn from this overlapping of these networks. We believe that ADN is an arena where people can communicate and interact with others to get new insights and reduce avoidable deaths. And knowledge exchange events are is a kind of a case in point. So in this slide, ADN itself is a network. In addition, we also build networks to reduce avoidable deaths. So ADN is a network, and we build networks at local level and national level and also at international level. To implement ADN's philosophy, we are experimenting with 2 different types of networking model. The first is called Knowledge Exchange Network. We call it KEN. And this network is particularly for those who want to find out yet unknown issues related to avoidable deaths. We believe if we don't try to figure out unknown issues, this will lead us to unexpected events that can usually cause a huge number of avoidable deaths. The second networking model is a local action network. We call it LAN. So LAN is for those who want to find solutions to known issues related to avoidable deaths. This network is for high-risk groups or the last mile or the most vulnerable who carry the burden of avoidable deaths. To substantially reduce avoidable deaths, both KEN and LEN are needed. So these are interconnected. So what do we do? So we undertake 7 different and yet interconnected activities to implement our philosophy. You could see on the right-hand side, in 2023, we launched our global campaign called International Awareness Day for Avoidable Deaths. It's celebrated on the 12th of March and also throughout the month. And we will be celebrating the global campaign next month. And I encourage many of the participants who are here to, if you haven't heard about this global campaign, please drop us an email and we would encourage you to, celebrate this global campaign wherever you are. Second, we do research. Our research areas are snakebite, drowning, tsunami, and maternal deaths. Number 3, we do knowledge exchange events through symposium, webinars, outreach, workshops, and today's event, which is a special session, which comes under our knowledge exchange events. We also do capacity building. of disaster responders and also of the at-risk population or high-risk populations through outreach workshops, and also of the first responders. We do publications. The publications are both academic and non-academic, and we also have a scheme called Future Leader and Junior Champion Leaderships. So these are for children who are below 18 and above 18. We can move to the next slide. So today we have a very important session, which is called the role of emergency medicine in reducing avoidable deaths in a resource-poor context. We have two speakers, Dr. Nikhil Paul and Dr. Santosh Pandey. Now, I really don't know much about emergency medicine, except for that we need anti-snake venom if an individual is bitten by a snake. But I really want to learn more, like Hideyuki mentioned right in the beginning. But a little context about this is that health emergencies, as we know, occur every day around the world. And with injuries, especially such as snake bites or road traffic accident or drowning, they come under the category of injuries alone accounts for more than 4.4 million deaths. And that was the number in 2019. And these avoidable injury deaths are basically taking place largely in the low and middle income countries. So deaths from injuries are avoidable. For instance, ADN focuses on drowning and snake bites, which we mentioned before. So for the reduction of these deaths, effective emergency care system could prevent more than half of the deaths and the third of the disabilities in the low and middle income countries, according to Reynolds et al. So despite gaps in healthcare, there are some heroes in our global towns, districts, and other villages and things like that who go extra miles to save lives. And today we have two such heroes as speakers, Dr. Nikhil Paul and Dr. Santosh Pandey, and I'm sure they go well and above to save an individual's life. And I can't wait to learn and listen to them. But before that, thank you very much to these two wonderful, as I said, they're heroes to us. And over to you. But before that, there's one final slide. So if you don't know about ADN up until today, please feel free to join ADN, follow us, and joining ADN is free of cost. And also, if you want to find out more about our international awareness for avoidable deaths, a global campaign, you could visit our website. So with that note, thank you very much. And over to Nimra.
Hello, everyone. Welcome to this special session. I am Dr. Nimra Chaudhary, and I will be chairing this session today. First of all, I would like to invite Dr. Hideyuki Shiroshita for the pre-poll. Over to you, Dr. Hideyuki.
Okay, thank you very much, Nimra. So, yes, as I mentioned, when we organize a special session, we always ask you to participate in the poll survey before the session and after the session. So this is a very tiny survey, consists of just 2 questions. So the poll does not evaluate speakers, but our session. This is purely for improving our program. So, okay, let me launch press session poll.
Hideyuki, if you don't mind, maybe read the question. So that
Right, okay. So the first question is, do you have any prior knowledge of the topics for today's session? The second question is, based on your current knowledge, i.e. up to the point of starting this session, please rate your current level of confidence on the usefulness of the topics introduced. Yeah, so we would like to wait until the response rate reaches around 80%. So far, we got 63%. So 17% more, 72%. So maybe at least one more answer.
think it's 72%.
Yeah. I think, yeah, people who can, participate already, so participated. So yeah, I think we should finish the PlayStation 4. What do you think, Nivedita?
I think we can close it because we are running
Oh,
out
yeah,
of
yeah,
time
yeah.
today.
Okay.
Yeah.
Yeah, right. Okay, so thank you very much. So yes, this is the result of the PlayStation 4. Yeah, later, yeah, we will have very similar question. So yeah, and then after that, we will compare the result before and after the session. So thank you very much. So over to you, Nimra.
Thank you. Thank you, Dr. Hideyuki. So we have two esteemed speakers today who will be sharing their expert opinion on this very important session topic. So first we have Dr. Nikhil Paul, who will be speaking on emergency medicine past and present. Dr. Nikhil Paul is the Regional Coordinator India for the Avoidable Deaths Network. He is an emergency medicine expert, founder of Outdoor Medics Private Limited, and certified instructor in ACLS, BLS, and PALS, specializing in wilderness medicine and disaster care. So over to you, Dr. Nikhil Paul.
Can you share the slides for me? Yeah.
Sure. Kelly, can you share the slides?
Yes.
Right. Good afternoon, good evening, all. Myself, I'm Dr. Nikhil Paul. I'm currently working as assistant professor in emergency medicine in Kasturba Medical College, Mangalore, in India. So first of all, I would like to thank Professor Nivedita Madam, Professor Hideyuki, and all the leaders of ADN for giving me an opportunity, giving us an opportunity. And of course, I would like to thank Dr. Santosh Pandey. He's my friend, colleague. We actually did emergency medicine together. So we had seen emergency medicine. We started emergency medicine together. So thank you, Santosh, for joining in with me to deliver this presentation. And in fact, so I'll keep it very simple as we have a diverse audience over here. So we have people from all walks of life. So some might be knowing what exactly emergency medicine is, some may not. We'll keep it very simple. So my topic for today is emergency medicine, past and present. Can you go to the next slide, please? Right. If you look into history, like emergency care has been always there actually. But most of the emergency care which was recorded is in context or in relation with the combat or the wars which was there. So if you look in, emergency is delivered from the word emerger. So that means immediate. And it was in 1792, Dominic Jean Larry. So this is one of the earliest recorded thing about the EMS or emergency medical services. So it was during the wars in Italy. So flying ambulances were introduced. You can see in the picture, Dominic Jean Larry and the flying ambulances which was introduced. The flying ambulances were introduced so that the injured soldiers were brought back to the treating facility. If you look into history, before 1960, you can see that the emergency care was mostly in a setup called as casualty. So casualty services. So wherein there was a duty doctor or a medical officer of a junior rank who will be seeing the patient in the beginning, evaluating and referring to other specialities. That system is still practiced in many parts of the world, in most of the low LMICs or developing countries. In fact, proper emergency medicine, maybe the first of its kind, might have started around 1960s in the UK as well as the US. In China, it was in around 1980s, the first of its kind was started. By 1990s, in developed countries like UK and US, in fact, it was in the US, subspecialties of emergency medicine came up, like pediatric emergency medicine, sports medicine, medical toxicology, hyperbaric medicine, pain medicine. A lot of subspecialties came in. We are from India. I am from India. It was not until early 2000s that the emergency medicine concept came up. So by early 2000s, instead of casualty, a lot of accident and emergency services boards started coming up. By late 2000s, it spread, and formal training program in emergency medicine was introduced around late 2000s. After 2010, it saw a rapid increase in training programs all around the country. Still in its early stages, or maybe baby stage, the emergency medicine is rapidly growing in India. So that is what we have in India. Can you put in the next slide? If you look around the world, we have three models of emergency care or emergency medicine or emergency services around the world. We have the Anglo-American model, the Franco-German model or the European model, and a neglect model. An Anglo-American model is something where we have a proper emergency department where emergency physicians who are trained in managing all kind of emergencies, we have specialized equipments, we have a dedicated emergency room manned by emergency physicians. So on the field or outside the hospital, minimal management is being done. The patient is being rushed to the hospital, wherein the initial management is done, resuscitation is done, or stabilizing the patient is being taking place in the emergency room. And finally, once he or she is stabilized, it is proceeded as if they require admission, they will be admitted. So it's more like a scoop and run. So emergency services is that like you don't manage too much on the field, but you go to the hospital. In the hospital, we have an emergency department, and further management takes place there. Now we have a Franco-German model or the European model where we don't have emergency medicine physicians, or we don't have dedicated persons, but maximum care take place outside the hospital at the field. The field work takes place a lot. The triaging, the initial stabilization, everything is managed on the field. The patient is brought to the hospital and is transferred to definitive care for, depending upon the problem, they will be referred to different specialities. Suppose if he is having a heart attack, he will be directly referred to the cardiologist. Suppose if he is having, she is in labor, so they will be shifted to the obstetrician. Then we have the neglect model, wherein emergency care is not much addressed to. So you have hospitals, patients come in, there is not much of care for emergency care. Moving to next slide. If you look into a proper ED or emergency department, so it comprises of a lot of things. So we have an ambulance or the EMS coordination center. So it's basically the ambulance parking area. It's not just a parking area, wherein there's a lot of things which happen over there, like handing over the patient. Then we have the next area, which is called the triage. This is a key area in the emergency department where triaging takes place. Triaging is nothing but sorting according to the priority. It's not like we have a first come, first serve for all the patients who come to the emergency. We go by certain priorities wherein we group patients accordingly or sort patients accordingly, and patients who has the highest priority or the most important triage will be treated first. Then we have something called the resuscitation area, where very sick patients or the highest priority patients are taken to, and immediate stabilization takes place. Other areas include a major trauma area. So different EDs have different setups, but these are some of the commonest constituents of common EDs. Then we have consultations rooms, might be there, may not be there, have a patient waiting area, have a minor as well as a major procedure room or operation theaters. Observation areas or ICUs or parking ICU beds are there in some emergency departments. A 24-hour dedicated pharmacy as well as a stat laboratory where you do point of care testing. Like, so you do faster investigations from the stat laboratory. So this itself is a hospital, in fact. Like, you have almost all the systems within a hospital inside a hospital. That is what is an emergency department. Moving to next slide. Just a little about triage. So we usually follow a 3 or a 4 triage system. There are numerous triage systems around the world. The commonest one, what we follow is we have a priority 1, 2, as well as 3, where priority 1 is immediate, 2 is delayed, as well as 3 is minimal. Then we have a priority 0 or an expectant or a dead patient. So for them, it's the least priority because we have to go for priority 1, 2, and 3 first. So immediate or priority 1 is who is having life-threatening conditions. Examples can be a heart attack, a tension pneumothorax, a cardiac arrest, seizures as well. Priority 2 is which patients who does not have immediate threat to life, but definitely they require definitive treatment. Examples can be trauma-related fractures, lacerations, like that means you have bigger wounds, as well as for which the bleeding has stopped. In fact, if it is bleeding all over, it becomes higher priority. Priority 3 is minimal, wherein you can wait. In fact, patients having minimal injuries or minor conditions and who are ambulatory or walking. Examples can be like mild fever, very minimal cut wounds, or maybe a long-term illness which is presenting as a new symptom. Like I said, priority 0 is expectant or dead patients. Expectant just means that even if you do maximum care, they may not survive. Moving to next slide. Like I said, we have different triage systems around the world. The commonest one, what we use is emergency severity index. Then we have the oscillation triage scale, which has a 5-level. Canadian triage and acuity scale is there. Manchester's triage system and field and disaster triage. There are numerous field as well as disaster triage system. In disaster, the priorities are a lot different. So you may not be able to triage like what we have in the hospital, because there is lot number of people who are affected within a short period of time. So our idea in a disaster is to give the maximum good for the maximum number of people. So disaster triage systems are entirely different. So I'm not going too deep into the various triage system. That itself will require a lot of time to discuss. Moving to next slide. Right. What are the benefits of emergency medicine? Like I said, we started where emergency medicine in a country like India was just developing. We didn't have proper proper emergency departments were just coming up. But we have understood over a period of time, emergency medicine affects the patient care in a very positive way. So what are the benefits? Immediate care, of course, based on the triage system. So we can triage patients accordingly. So the most sick patient or the ones who requires immediate resuscitation will get immediate care. So thereby we can reduce the mortality, in fact. So then I'll go it quickly. So we have specialized medical teams wherein, so we are properly trained emergency physicians within the ED. So then we have state-of-art equipments. We have almost all the equipments which can be used for various procedures. Triage and patient prioritization we have already discussed. We act as a coordination link between various hospital units and departments. 24/7 accessibility of proper consultants, getting so we can give maximum care, and of course crisis preparedness, especially in case of disasters. Moving to next slide. Just want to discuss what are the limitations of emergency medicine right now, especially in LMIC. So still many places, as I told, it's a casualty system. Accessibility is a main problem. Most of the emergencies are located in cities, especially tier 1 and tier 2 cities. The rural population has less accessibility. Affordability is a main issue. Specialized procedures requires more, cost more. Again, affordability becomes an issue. Acceptability, now the emergency medicine concept is still gaining its acceptability because people have been following, especially from the medical community. The people have been following the system for years, the casualty system. So changing from casualty to emergency takes a little time. Awareness, of course, for people have to be aware that we have a system in the hospital wherein you can bring the patient so far so that we can manage the patient. Lack of proper EMS is a big problem, like especially in LMIC, if we don't have a proper EMS or emergency medical system outside, pre-hospital system, in fact, the ambulance and pre-hospital systems, we don't have proper transport. Again, you are losing time. We have something called the golden hour and the platinum minutes. So lack of insurance coverage is again a problem, like which requires which is again a topic of discussion. Moving to next slide. So just wanted to put in two pictures. The first picture was a girl who died in a classroom because of a snake bite. She was rushed to a primary care center where no emergency care was available, no anti-snake bite venom was available, and the patient was shifted to a tertiary care center. On the way, she passed away. Unfortunately, this was around 3-4 years ago. And the second picture is which happened in 2017. Pedestrian was struck by a four-wheeler, and he was taken to 4 different hospitals, and he didn't get proper care and he succumbed in the ambulance. So all these things, keeping this in mind, so emergency medicine, developing a proper emergency medicine system can positively affect and reduce a lot of avoidable deaths. The last slide. Right. So in LMICs, the future, so we deal with avoidable deaths. How can emergency medicine impact the LMIC in the future? So trauma, effective pre-hospital care systems can improve. Poisonings, supply of antidotes in as well as snake bite. You can get antivenoms everywhere. Other problems which can improve because of emergency medicine might be the sepsis, especially related to childbirth. Then you have submersion or drowning, as well as the major role in disasters. Thank you. That's all what I had. Thank you all.
Thank you so much, Dr. Nikhil. This was very, very informative. So for our next speaker is Dr. Santosh Pandey, who will be speaking on emergency medicine strategies in acute poisoning. Dr. Santosh Pandey is a senior consultant and head of emergency medicine at the Maharaja Agrasen Hospital, New Delhi, in a teaching faculty for NBMS, NBEMS, and ATLS, BLS, and ACLS instructor. His expertise includes toxicology, disaster medicine, and emergency medicine academics. Over to you, Dr. Santosh, for your talk.
Yeah, am I audible?
Yes, yes, you are.
Yeah, thank you everyone for giving us platform for talking on this platform from both of us. And special thanks to Dr. Nikhil for letting everyone know what is emergency medicine. We've actually both were physically in 2016 batch, past 2018, both are working as a emergency physician in India. Now, my topic is we'll discuss how incorporating emergency medicine helps in reducing mortality, especially in toxicology emergencies. I'll be very quick. Basically, I'll give a just brief review how to manage an intoxication patient that comes to ED. So our ED approach will be basically will mostly initially focus on the resuscitation. So any patient that comes to ER with intoxication, any intoxication, basically we follow ABCD approach for the resuscitation. That is the airway management, breathing management, that and circulation management, and the disability in the exposure. Our main focus is on reducing the effect of the toxin, that is by reducing the effect of the toxin, that is by enhancing by elimination of the toxins and or by neutralizing the toxins with the help of the antidotes, and it ends up with the post-resuscitation care for the best outcome of the patient. Now, what is the importance of important timely accurate resuscitation if we do properly? It helps in reducing the prevention of complication and fatalities, and helps in stabilizing the patients of the vital function of the patients of the intoxication patients. It helps in improving prognosis and the recovery of the patient, and this is all being done with the help of appropriate use of the antidotes and the treatment facilities available for this all toxicology emergencies. If we talk about approach to resuscitation, as I told, usually we follow the ABCD approach. That is the part of the primary initial assessment. We follow the airway, breathing, circulation, disability, and exposure approach, in which we try to address the all life-threatening emergencies and try to intervene in that. As soon as the initial assessment is completed, it is followed by secondary assessment, which involves thorough physical examination and assessment of the extent of the toxicity. And then we focus on the reducing the effect of the toxin. That can be done with decontamination techniques or antidotes specifically available in ER. All of the ERs are having specifically antidotes. Most of the ERs that are in the urban areas all are having most of the specific antidotes for all the possible toxicology that can happen. And that can enhancement of the toxins can also be eliminated with some few techniques that also I'll discuss in the later on. And then we end up with monitoring and follow up the patient. That is the part of the post-resuscitation care. Now, there are a few challenges. Any patient toxicological cases we accompany, the important challenges that comes in the airway is difficult. Like some of the patients come with multiple secretions, obvious secretions that can be as a part of, if we talk about OP poisonings, that can be as a part of sludge dumble complaints. It's very difficult to manage airway in that cases. Some patients can come with status epilepticus seizures, especially if we talk about cobra toxins. In that case also it's difficult to manage the airway. Then many patients come with the airway edema or burns that we have seen many cases of vascular poisoning. Basically they'll have upper airway edema. It is very difficult to manage airway in that cases also. And some will have laryngospasm also as a part of toxins. So in that cases, what we do, we usually use lateral leg brace position for the transport, when you transport patient for the paramedics to the ED. In that case, you can use this position so that they don't aspirate patients. And if required, you can use NPO, OPA and remove secretions, vomiters and blood obstruction in the airway by gentle suctioning. And you can anytime consider rapid sequence intubation as soon as patient comes to ED. Now, what is the problem? The problem is difficult airway. So whenever you suspect this patient is having a difficult airway, in that cases, you can consider awake intubation. Again, awake intubation is the expertise. Patient and any experts has to be very confident to do this intubation, or else we can go for surgical airway also. That is also like usually very again it is again expertise. For this you need to have basically what we do is scalpel ricothyrotomy. Again expertise things that can be considered in difficult airway things. Now, what are the few drugs that can be used in securing the airway? Most commonly, this is the pre-medication use. I am fond of using lidocaine because most of the patients, they come with high raised intracranial pressure or seizure coming to ED with, as I told, in kind of neurological intoxicated patient. In that case, lidocaine can be used. Other drug is midazolam that can be used as a pre-anesthetic medication. If you talk about inducing agents, most commonly drug used is ethomidate because it's a cardiostable drug. If you talk about propofol, if the patient is having on the higher hypertension, in that case, propofol can be used, or ketamine can also be used with 1 mg per kg, 1 mg, 1 to 2 mg per kg per dose, per kg IV bolus dose. Now, paralytics, either scoline or rocaine can be used. Awake intubation, I told the very good drug is dexmedetomidine. This is the only drug that has less effect on the respiratory depression. So whenever you try to do awake intubation by expertise, in that case, lidocaine locally can be applied and dexmedetomidine can be used for awake intubation for difficult airway. Now, coming to the breathing and circulation. Now we spoke about airway management. And we spoke about difficult airway management in here. If the patient is not responding, airway is not secure, we'll secure the airway. Then comes to the breathing and ventilation and the circulation part. Basically, airway, breathing, circulation, all these things goes parallel by parallel. But now we'll talk about breathing. In breathing, we monitor oxygen saturation of the patient, monitor respiratory rate, efforts, and look for the signs of respiratory distress or failure. We target to manage SATs level more than 94% if the patient is requiring oxygen. And meanwhile, airway and breathing is managed. Whenever you get a chance, go ahead with antidotes. Specifically, antidotes are many antidotes are available in that which are used for reduce the respiratory depression. If you talk about in opioid toxin or opioid toxicity, in that case, naloxone can be used. That is used to reduce the respiratory depressions. And regularly monitor the patient with regular blood gas and monitor settings as soon as to settle the uh, patient's hemodynamic in that case. If we talk about ventilator setting, most commonly we use AC/VC mode, and you can use the tidal volume 6 to 8 ml per kg, depending the patient weight. And respirator can be started with 12 to 13 and can be increased or decreased as per the patient requirement. Starts with FiO2 of 100%, and then we can titrate itself and keep up start. We can start a PEEP of around 5, and it can be again titrated as per the patient's requirement. So this was the breathing component. Then comes to circulation component. What we need to, once the airway and breathing is sorted out, then we comes to circulation. In that case, we will do with the vitals monitoring. Patient will be attached with the initial cardiac monitors to look for the heart rate, blood pressure and all, and ECG monitoring. Now, most of the toxin patients, they come with the broad spectrum tachyarrhythmias. In that case, ECG monitoring is very important, and you have to intervene at that point only. Then peripheral perfusion, check for the signs of poor perfusion, such as capillary fill time, motile skin, or ultrameter status, and intervene for that. Fluid status, assess for the signs of hypovolemia. Whenever you think patient is in shock, go ahead with fluid hydration. You can use Ringer's active crystalloid balance with like kind of 10 ml per kg, 10 ml per kg bolus dose. Usually we use 10 to 20 ml per kg bolus dose, and then we can assess the patient's whether the patient is responding or not, and then later on we can proceed with the inotrope also. And then blood test. Now that comes on in circulation only. In that case, you have to do the routine blood test of the patient. Other than this, if you have a specific test for the specific toxins, like kind of if you talk about paracetamol poisoning, we should send the paracetamol levels. And other than this blood levels, we should send the urine toxicology screening also. In that case, if you don't know what patient is being intoxicated with, in that case, urine toxicology screening helps to rule out most of the toxins. But again, availability is a factor. Most of the centers are not having this test centers or test facilities available at the center. But if you have available, go with that. As I told, patient can be treated with isotonic crystalloids, normal saline, to maintain adequate perfusion. And the patient is not responsive to the fluid therapy. In that case, norepinephrine is the drug of choice to maintain a map of near about 65 Hg. And then specific antidotes has to be used. As I told, like atropine can be used in OP poisoning, digoxin can be used in digitalis toxicity. And apart from managing airway breathing circulation, go and follow the SLS protocol, whatever has to be done to treat the normal life-threatening emergencies. Now we have discussed airway, breathing, and circulation. As a part of primary survey, if you talk normally ABCD management, in the normally D is disability. But in toxicology emergencies, D is not disability. D is for detecting and correcting few things. What are the things that to be detected and corrected is, first is hypoglycemia. If it is patient is having, it has to be corrected with dextrose. Next is hypothermia and hypothermia. Both hypothermia kills. So hypothermia has to be detected and avoided while doing the patient managing the primary survey in that case. And then seizures. Any patients coming, you have to detect seizures. Patient having seizures, like I told, some toxins are brain toxins. Most probably, if it encounter in the local practice, snake toxins are very commonly cobra toxins. In that case, seizures and this seizures have to manage in toxicology with the benzodiazepines. And later on, we can treat with the antiepileptics also. Now then, exposure management. Exposure, remove the patient with contaminated clothing. Skin and eye decontamination of the patient is also important. We can wash the skin thoroughly with the soap and water, and eye irrigation with copious amount of water for about 15 minutes has to be done. Basically, the ER which are well developed, they have a decontamination zone that is mostly out of the ER. So we decontaminate the patient there, and then we take in the patient in the research area. Usually the good ERs are having this decontamination zone. And then assess for signs of toxic exposure and look for burns, rashes, or any chemical stains on the skin in order to identify any specific toxins if we know, so that antidotes can be given properly. Now with exposure, we do environment control also. So ensure proper ventilation for the patients and isolate the patient in a designated decontamination area, as I told previously. And wear PPE. This is very important because we have to save ourselves from the secondary exposure also. Like most of the patients, like we have seen patients in Bangalore also, when we were there with Nikhil, patients will come with snake in their hand. This is the snake he has bitten. Patient will come with a petroleum products bottle in their hand. Patient will come with this liquid they have taken, this paraquat poison they have taken, but they will bring that poison in their hand only. So that makes our ED staff being exposed for the secondary exposure. That has to be prevented. That can be only be done by using personal protective equipments and safe disposal of the patient once the patient is exposed and environment control is maintained. Now, once you have started doing the primary assessment, you're about to finish the primary assessment. Yeah, after that, you have to do a risk assessment of the patient. But this is done only after completing the primary survey only. What does it include? That includes agent, what agent patient has taken, try to find out the patient. Most of the time it is happening, we don't even know what is this poison. Like when we were doing a postgraduate that time, postgraduate PG time, that time the absent patient comes with all out poisoning. We didn't even know at that time, what is there in all out poisoning. Then we'll read in that, okay, this is something called pyrethroid or something, alcohol toxins are there. Then we read for that and we should treat for that. So that is the thing. Everyone should be knowing what are the specific toxins can be, patients can be intoxicated with that, and what are the antidote specific available for that. And doses, what amount he has taken, what time he has taken. If you talk about paracetamol toxicity, in that case, time is very important. When he has taken the paracetamol toxins and what is the effects, that what time we should do the paracetamol level, in that case, timing is important. And then clinical features and the prognosis, progress of the disease of the intoxicated patient. And then patient factors and comorbidities has also to be considered, because that adds on the patient disease progression of the patient. Now, what are the modalities available while the patient is, we have tried to resuscitate the patient with airway, breathing, circulation, exposure. Now, what are the modalities available that goes in parallel with ABCD approach? The first is GI contamination that we do very commonly in emergency department, and that is the most important drug is charcoal. Charcoal is a very porous thing that is used along with the gastric lavage. 1 gram per kg dose. Now, important thing is that this can be this is mostly in the form of cubes also. This can be in the form of powder also. You can wait and put in the normal saline and do the gastric lavage. Now, important thing is that this lavage helps when the patient comes to ED within 1 hour only. So, best result within 1 hour. Now, one more important thing is that when it can't be used, it's not like charcoal can be used in every case of the toxicology. Like patients comes with heavy metals like lead, mercury, or a patient is having petroleum products, hydrocarbons toxicity, or patient is having methanol alcohol. In that case, also charcoal is not much useful. And patients, some things can form benzoates like kind of salicylates. In that case, also charcoal is not much effective. So in that case, you have to think about other causes. So in such cases, what can be used? We can do whole bowel irrigation. So whole bowel irrigation is done with polyethylene glycol. This can be helpful in such cases where charcoal is not helpful for that, and like or other under condition like patient example, patient is having like kind of body packers or packs of cocaine in the body. In that case, charcoal will not be effective, because that drugs are released very slowly in within the body blood circulation. In that case, we can use for whole bowel irrigations, and that is also useful for drugs which are having higher amount of enteric and enterohepatic circulation. And other elimination options are hemolysis and hemodialysis, but this can be used only when the patient is stable. In case patient is unstable, in that case, you can go ahead with controls replacement therapy. And this hemodialysis, or what are the dialyzable drugs? The commonly dialyzable drugs are salicylates, lithium, methanol, ethanol. And hemoperfusion can also be done in that case of theophylline and carbamazepine. And CCRT will be helpful when the patient is very unstable. Forced diuresis can also be used in case of phenobarbital or chlorpropamide toxicity. Urinary alkalination is done with soda bicarbonate. That is done in case of poisoning with weak acids like salicylates, methotrexates, and phenobarbital. Exchange transfusion usually we don't do in like I'm not incorporated with exchange transfusion, but this you has to be done in case of like neonates with the severe methemoglobinemia. We have seen cases, but that is done in the pediatric ICU, not in the emergency department. And this multiple activate dose charcoal. This is again, I told the dose of charcoal is 1 gram per kg, but after giving the initial bolus of 1 gram per kg, if it give the charcoal by around half of 1/4 of the dose every 4 hourly, then that becomes a multiple dose activated charcoal. Now, when to use this? This can be again used for the drugs which I told previously, drugs which are having enterohepatic or enteroenteric circulation is much more in that case. That in such cases like carbamazepine, theophylline, or phenobarbital. Now coming to the specific antidotes. So whenever the more early you use the antidote, the more fruitful results are there. So we should be knowing when to use these antidotes and what are the doses of the antidotes, how are they given, whether they are given by the NEPs, whether they are given by subcute, or whether they are given by the IV injections. We should be knowing the appropriate doses, and while giving the antidotes, monitoring and supportive care of the patient has to be done. Now, whenever you have doubt, like imagine a patient comes to the peripheral center, you don't know much about this. Snake bite has come, I don't know ASV dose, how much ASV is there, ASV is not available. So whenever you have doubt, in that case, keep an eye on your regional center of the Poison Center in Delhi. Like in Delhi, we usually call AIMS Poison Center whenever we have doubt. Sometimes we have incompetent. Like I have been like in the last year, I saw a case where one factory bursts in Faridabad, and I got like 20 patients with methanol toxicity. Everyone got panic on that day. What to do? What to do? I didn't have home visual at my center. So what to do? Some person told whether we should give ethanol into the IV for the patient. Medicine consultant said, no, we can't give the ethanol IV. This is unethical to practice like that. But in that case, when we call the poison center, what can we do now? Initially, all the patients and managers all were kept in ICU. Few patients become blind. In that case, the dialysis was done. But initially, if you have doubt, I don't know what has to be done. In that case, feel free to call your the local poison center. They'll help you out because they have data available for the most of the poison days. And now, slowly, I'll brief you about what are the specific antidotes that one should know. So naloxone is used in opioid overdose. Naloxone basically used as a like kind of 0.4 mg, 2 mg, 2 mg you can use maximum to the 10 mg. And it can be given through the IV, NEPS or subcut also. Mostly we give IV in responsive patient. And subcut also can be considered. NAC. Again, NAC is used, I told in the paracetamol toxicity. The appropriate dose of the NAC is 150 mg per kg. That is given within 1 hour. Then 50 mg per kg has to be given over 4 hours. Then followed by 100 mg per kg has to be given over 16 hours. So the NAC is given as an infusion dose over the 24 hours. And then atropine is the antidote for the OP poisoning. There is incremental dose of the atropine you can get in the books also. But what is important is the atropine dose is quite high in case of OP poisoning. And then
I'm sorry, Dr. Santosh.
yeah.
I'm so sorry. We are running over time. So sorry about
Yeah,
it.
this is I
We
think on the
need to-
second slide,
Yeah,
ma'am.
yeah,
Just talk, ma'am. Then digoxin specific antibodies can be used in digoxin toxicity, omeprazole, methanol, methylglobin, desferoxamine, iron toxicity. There's lists of drugs. You can go through the books. So if you go back there, you can go through the books also. There's multiple drugs available, antidotes available. But one more main motto is that everyone should be knowing about the specific antidotes. And this is the monitoring and the follow-up of the patient has to be done throughout the hospital stay of the patient when stays, why the patient is in ER or in the ICU. Continuous vital monitoring is important. Neurological assessment is important. Cardiac monitoring is important. Go with the lab test, what you have done, what you have sent, whether it is blood levels or urine toxicology levels. And the end, you look for the efficacy of the antidote, whether the patient is responding to that antidote or not. So I'll end up with this small mnemonic for managing any intoxicated patient in the emergency department. That is RRSI dead patients. R is for resuscitation, risk assessment, supportive and monitoring care, investigation, documentation, decontamination, enhanced elimination, antidotes and disposition of the patient to the ICU and from here ICU to the home. Thank you, everyone. So we are open for any doubts. Sorry, I was a bit fast because it's a very, very vast topic. Toxical emergencies is very vast. It takes days to teach and read about that. But this was just a basic thorough. Whenever such patients come, how to do a primary survey and secondary survey. And you can do instant management and go and read about the antidotes. Each and every antidote has to be read. Thank you.
Thank you, Dr. Santosh. That was very informative. Now I would like to invite Professor Nivedita Ray Bennett for the Q&A session, which will be a very brief session. I'm sorry, because we are running over the time.
Thank you, Nimra. Thank you, Dr. Paul, Dr. Pandey. That was really fantastic. So new, so different, lots of learning. So if, we are short of time, if any of the participants have questions, please drop it on the chat box. And if I know we are short of time, but what we do usually at ADN is that we usually collect the answers and then we post it on the website. And we also send an email to all the participants. So your question will not be unanswered. It will be answered. It's just that maybe not in real time, not live. So don't worry about that. So please drop your comments on the chat box. I haven't seen any, but there was one comment from Dr. Kailash Gupta. So Dr. Gupta, if you can unmute and please feel free to ask or share your comments or thoughts, whatever, but you have 2 minutes for that.
Yeah, thank you very much. I need only 1.5 minutes.
Okay.
Hello, sir.
Now my question is addressed to Nikhilji.
Yes, sir.
I'm involved in research, and my question is, do you know that autograft is being performed at the disaster site anywhere in the world? Yeah, I repeat, I'm interested in knowing if you are aware of autograft, tissue transplantation at
Yeah.
the disaster site, not taking the patient from disaster to the hospital. Are you aware of any of this? And number subsequent whether this can be done? Yeah, over to you, Nikhilji.
Yeah, the thing is, it depends upon how good the disaster care is in the country or in the settings what we are in. Like in India, what we see is it's absolute chaos or haphazard when the disaster happens. Uh, there are many places where there are specific. So disaster is a state of chaos. So as you asked me, like performing an autograft at the site, again depends upon a lot of things. So we have to go for a proper triage, see whether the patient is immediate or expectant. So see whether they might benefit because of this graft or whether they won't. So the priority in disasters might be different. So we are not dealing with one single patient. We will be dealing with masses. So such definitive procedures, there it might come in like as things develop later, but as of now, I'm not aware about this procedure being done at the site. Might be there, which I'm not aware of, but then especially in a country like ours or maybe any of these developing countries, we are always short of resources. We don't have a proper transport facility. We don't have a proper emergency department. So the priority itself is different. So I would say might come in later, but as of now, I'm not aware about like can happen. Like anything is possible. Like can happen. Like
Okay, Nikhilji, I've been doing research on mass fatalities management for more than 20 years. And Indian Council of Medical Research has invited investigator-initiated small research grant extramural. I
yes.
invite you to be co-investigator. That 1st April is the deadline. So my proposal is to do autograft because if we talk of organ transplantation, it may be constituted as trading in organs and all those things
Yeah.
problems are there. So to start with autograph, so I got a team of researchers and I met the ICMR Director General also. So I will communicate separately afterwards. I want you to be co-investigator.
Thank you for the invite. Thank you.
Okay,
Thank you.
thank you very much.
Thank you, Dr. Gupta. That's fantastic. So, any other comments? I have one question, actually, Dr. Paul. Maybe a daft question, but in the priority of that slide, which has a priority 1, 2, 3, and then the ones who are about to die. So, where would the snake victim fall in? Is it category 1 or priority 1 or priority 2?
Snake bite victim comes in priority 1.
Priority 1, okay.
Because we don't know whether they are bitten by a venomous or a non-venomous snake, whether they
Okay.
have like complications related to the snake bite. So comes in unless otherwise proved that this is a non-venomous snake and even then we keep it as priority 1 and we test and then we detriage or get to a lower triage if they are okay.
I have one more question for you and then one for Dr. Pandey. So, Dr. Paul, in another slide, one of your slides, you mentioned about the different models of emergency medicine. Okay, so one is that Anglo model, I think.
Yeah,
And
Anglo system actually.
Anglo system. Second
Anglo-American
was
system, UK and America. Anglo-American system.
Anglo-American, then the European, and then the neglected. So where does our Japan, so they're South, Japan is not Southeast Asia, but there are a few other, Hideki, Asia, East, extreme, I don't know. So where would does Japan has a model that does not fit the Anglo model
Japan
and the
has a
European
proper
model?
emergency medicine system. That's what I understand. So it will be like they have a dedicated emergency room, emergency physicians. So it comes under Anglo-American, I
Or
think.
it comes under Anglo medical.
Yeah, I think so. Yeah.
Thank you very much, Dr. Paul. So, Dr. Pandey, I have one question. You mentioned
Yes.
towards the end about the toxics. You mentioned, so there are different types and varieties of toxics. Toxics, yeah. And you mentioned that when the patient comes, in terms of exposure, you will remove the clothes, and also wash with soap. Will you do the same for a snake bite?
No, snake bite case where decontamination is not required. No. So decontamination is required where the patient, like, you have fumes in the air, like petroleum products, kerosene poison, hydrocarbons. In that case, the cloth has to be discontaminated. But snake bite cloth has not to be discontaminated.
Thank you. I have no more
I
comments.
would like to add,
Yes.
so we can remove any constricting clothes. Like if the cloth is too tight, okay, you can remove it because soon the swelling will increase. So it's better to remove the clothes earlier.
What about a drowning victim? Do you need to remove any clothes or anything? If they have come for CPR or anything?
Generally for CPR, we remove the upper cloth because we have to act directly on the chest.
Thank you very much. I don't see any more questions or comments in the chat box. So I think with that note, I'm going to close my Q&A session. Did you get that? Was fantastic. So over to you for the post-poll survey.
Right. Okay. Thank you very much, Nivedita. So before I launch the second poll, let me express my gratitude also. So thank you both Dr. Nikhil and Dr. Santosh very much for your informative talk. So both talks are great. I could learn lots of new things. Thank you very much. Good. So yes, now let me launch second poll. So where is the poll done?
Nikhilji, can you send me your email and phone number, please?
It's back on this one.
Yeah, I'll put in the chat box actually.
Okay.
Now, I think you can see the post-session poll. So after attending the special session, how would you rate your level of confidence on the usefulness of the topics introduced today?
Hideki, unfortunately, I have not been able to vote. I don't have that function. I can't really take part in the poll.
Okay. But I don't think it's a good idea for us to join the poll, I think.
I
Yeah,
should, because I
because
don't have much knowledge on that.
yeah. We are the organizer, so yeah,
Okay.
we should listen, the people's voice. So
Okay.
yes. Yeah. Oh, already 88% of people participated. So thank you very much. Yeah, let me share the result. So this is the result. The ratio of very confident was 38% at the first poll, I think. So, but now it rise to 50. So we are very grateful for this result. Yeah, the detail will be shared on ADN's website later with recording. So thank you very much. Thank you. Okay, over to you, Nivedita. Thank you. Oh, you are muted, Nivedita.
So it's just for me to conclude the session now? Yeah?
Yeah, it's a
I
concluding
think so,
remarks
yeah.
now. Thank
Well,
you.
I just
Yeah.
want to thank two wonderful speakers, Dr. Santosh Pandey and Dr. Nikhil Paul. And as I said, you're not just speakers, you both are heroes. You work in extreme conditions with limited resources. So no, thank you very much for that. And I also would like to thank our ADN team, Dr. Nimra Chaudhary. It is 3 o'clock in the morning in New Zealand. Our Kelly, she's worked hard. We have Fahim, Sadia, Mariam, a fantastic team. There's a lot of people who are working behind to deliver this 1 hour session. So thank you very much, the ADN team. Thank you to all the participants for registering for the event. The recording will be available on ADN's YouTube, and we will circulate the link. It takes a few days to do that, but we will circulate it. You will receive an email, and it will also be circulated on our social media outlets. So stay in touch. And we have lots of special sessions upcoming. We also have the global campaign upcoming in March, and I encourage and invite both Dr. Pandey and Nikhil. Will have to do it anyway to celebrate our global campaign, to raise the wonderful work that you are doing. It's your work, the global campaign gives an opportunity to let people know what you do and how lives can be saved. So thank you very much with that note. So good evening and good afternoon everywhere, and goodbye.
Thank you all. Thank you.